Hello, good evening, everyone, and welcome to this Sandoz symposium here at ECCO in Copenhagen. It's a great pleasure to welcome you here to this symposium entitled Defining the Future of Inflammatory Bowel Disease Care, the Pivotal Role of Personalised Treatment. I'm Peter Irving. I'm a gastroenterologist from Guy's and St Thomas's Hospital in London, and it's a great pleasure that you're here. Thank you for coming and spending the first part of your evening with us. These symposia are always important to everyone, particularly to the companies putting them on. And so one of the really big things is they need your feedback, okay? And they need your ideas about how this can be done better. And you will have noticed as you came in on the side here, there's little feedback things. They're a little bit like the things that you fill in at the airport to say how security was. And if you can just feed back at the end of the symposium just to give some indication of how you felt about it. And hopefully you'll be choosing the green face, but of course that's entirely up to you. So we have a great program for you this evening. Obviously, we're starting with an introduction, and I will talk shortly about the myth of the typical inflammatory bowel disease patient. Jonas is then going to introduce the next session. Jonas from Örebro in Sweden, and then I will be asking both him and Marieke Pierik from Maastricht about some of the key questions about inflammatory bowel disease subgroups and about how we hit the mark in those patients. It's then great that we have someone who's not an IBD specialist, but in fact a rheumatologist. And I think when we deal with inflammatory diseases, it's really important to remember, in fact, that there are lessons that we can learn from our specialist colleagues. And so it's great that Frank Behrens from Frankfurt in Germany is here and is going to talk to us about some of the hidden gems of rheumatology. And of course, many of you will know how much we learn from rheumatologists over the years. And then we're going to finish the evening on a high. I always love hearing Claudio Fiocchi talk. He gives outstanding talks that take us to a different level, and I can't wait to hear him tell us about personalised treatment for IBD, of course, but why and how. After which we'll have a few question and answers if you have any before closing. So I'm going to talk a little bit about the myth of the typical IBD patient, and I think it really is a myth, and that's because inflammatory bowel disease, of course, is not just one disease; it's a whole range of diseases, and in fact, it's not just a disease of the gut; it's really a systemic immune disease, and we can think of that in several ways. We can think about the fact that IBD causes inflammation outside the gut as well, and these pictures show us some of the extraintestinal manifestations that we have to deal with, and we're used to the fact that people have problems with their joints, their skin, their eyes. Of course, people have inflammation causing problems elsewhere, and the data over on the right-hand side of the slide there talk to the fact that not only are our inflammatory bowel disease patients at increased risk of venous thromboembolism, something that we're very familiar with, but in fact that inflammation is also associated with arterial disease in the form of cerebrovascular disease, cardiac disease, and even peripheral artery disease. So let's not forget that inflammation in inflammatory bowel disease is not just located in the gut. And then, of course, the other thing to say is that inflammatory bowel disease is not just one disease, and that's because we're not all identical people. We are complicated organisms, and in fact, we have a great number of phenotypes, not only in how we look and how we behave, but indeed in how our guts behave and how inflammation in the guts behave. And two very quick examples of that. You'll all be familiar with these schematics here, where people described how their disease behaved, whether that be Crohn's disease or ulcerative colitis, with different disease courses over time. And of course, different people have different ways in which their disease manifests over the years. But also, of course, people have different disease severity. And again, here's just a lovely example of a study that came from James Lee and colleagues in Cambridge, which identified that just by using transcriptomics, you can see that people often run very different disease courses that you can actually define early on in their disease. They can have a severe disease course, they can have a benign disease course. So we're clearly dealing with a whole range of diseases here, and that creates a lot of problems for us. First of all, we have multiple phenotypes. Secondly, we have different goals, not only between patients, but probably in the same patients at different times within their disease. We have multiple treatment options, but the question is, how do we decide? So I'm going to hand over to Jonas now, who's just going to give us a few words on that.
Thank you, Peter. So with respect to the question of how we're going to decide, so first of all, what are our options? If we take a bit of a historic perspective on that question, so in the past, we aimed to improve symptoms since we were restricted to conventional therapies. And at least in the context of Crohn's disease, we were not able to go beyond aspects of symptoms or in best scenario to achieve clinical remission. But with time, we also had the approval of the anti-TNF agents for the treatment of Crohn's disease and subsequently also for ulcerative colitis. Well, that was a real step change when it comes to the treatment of IBD. For the first time, we had a targeted therapy, and a targeted therapy that allowed us to even reach endoscopic remission also in patients with Crohn's disease. And that said, we also redefined our treatment goals, and for the first time could potentially also impact on the future disease course, even at long term. And since then, we also seen other biologics, such as ustekinumab and vedolizumab, and more recently, also the introduction of the small molecules with the JAK inhibitor, tofacitinib. Well, so how do we take that decision? Well, as clinician, we of course have to take into account the disease activity, but that's just a cross-sectional question, more about the current scenario of the patient today. But there are also other dimensions of the disease that we need to take into account. Aspects such as mucosal lesions, and where are those located in the gastrointestinal tract? Aspects such as the inflammatory load overall, and if the inflammation is only located in the gut or if it's systemic. Beyond that, it's also the aspects of the disease history of the patient. Has he or she been hospitalized, undergone surgery, had postoperative complications? And as you mentioned, Peter, are there any other systemic extraintestinal manifestations? And as well, the previous response to the drug that the person been exposed to. And in the end, the very important aspect is, of course, the cumulative impact of the disease on the daily life for our patient. So with that, we try to incorporate not only that disease activity, but also the aspects of the previous disease course, as well as the inflammatory burden and the impact of the patient. And in that sense, also, of course, we need to take into account the preferences of the patients. And with that, we're trying to look into the future. But the problem is that there are few robust markers that provide guidance. We sort of say lack that roadmap that could identify patients with a poor future disease course. And you could, of course, argue that there are several clinical variables that may help us. But the problem is that if you add those up, you add up with aspects such as age, disease extent, CRP, steroids at diagnosis, smoking, and mucosal ulcerations in patients with ulcerative colitis. And in the end, you more or less have your entire ulcerative colitis cohort of patients. And similarly, the list is even longer for patients with Crohn's disease. So in these type of situations where we have chronic conditions, where the prognosis is associated with a high degree of unpredictability and uncertainty, we, in this type of low validity environment, as clinicians, perform worse than simple scores of algorithm, even if we are experts in that sense. So based on that, we're trying to decide and do our best, but there is an unmet need, so to say, with respect to future disease course, and to be given that roadmap by applying robust marker of the future disease course.
Thanks very much, Jonas. So we're going to talk now about IBD subgroups and the secret of hitting the mark. And what we're going to do is do some questions here. And Marieke and Jonas are going to try and answer some of those questions. So here's the first one. What do you consider first when you're making treatment decisions?
Well, in terms of treatment decisions, we sort of say primarily look upon or restrict that to IBD drugs. Of course, then I need to take the inflammatory burden into account in first case, I think. This, since these drugs are anti-inflammatory drugs, or at least they have such properties. And having said that, that doesn't mean that I can ignore the aspect of the impact of the patient by the disease overall, but it might be that I need to take other actions or to add on other types of treatment to address those facts that are not primarily related to the inflammation.
Sure, and how do you best assess that inflammatory burden?
Well, the inflammatory burden, I think the gold standard is still endoscopy combined with imaging if we go into aspects of small bowel disease. But few patients accept frequent endoscopies, and it's also associated with risk since it's an invasive maneuver. So to some extent, we also have to rely on proxies of the endoscopic activities, and that's then biomarkers. And of course, there are quite a bit of a difference throughout the world which type of markers we use, but such as here in the Scandinavian countries, there is high use of calprotectin. In other parts of the world, you might rely on ultrasound and other types of investigations that could help you with the kind of guidance on the inflammatory activity.
Okay, well, let's move on then. And so what are the key factors that drive your selection of different treatment options, Marieke?
Well, what is already stated out really nicely by Jonas, we always first look at the disease severity, complications of the disease and the disease extent to select the optimal treatment strategy in every individual patient. But then, of course, especially in the elder patients, we also try to estimate the risk of side effects of drug treatment. And in elderly patients, we are very reluctant to give combination therapy, especially for a longer period of time. And then maybe in the very young patients, that's especially, I think, an item for the pediatricians. You also have to make sure that patients are actually going to take the drugs that you are prescribing. So in that specific case, you need to take a lot of effort to explain why treatment is important and if patients are willing to do what you think is the best treatment strategy. So sometimes you change because you think otherwise the patients will not be adherent. But still the extent and the severity and the location will be the first thing we take into account.
So I'm going to ask you a controversial question now. You talked about elderly patients. What is old?
Yeah, well, and I really think that we should be better in doing frailty scores, what the geriatricians are very good at. So it's really difficult to give a cutoff age. So you really have to take into account comorbidities, smoking, and other factors. Some people are old at 65 and some are still quite young at 80. So I think this is really now that every doctor needs to assess on an individual basis. But I think above 75, combination therapy starts to be really risky.
But a good diplomatic answer, I like that. So what do you think, Jonas, might be a decisive factor for you to decide actually you're really going to go for a top-down approach?
Well, I think you go for a top-down approach based on the disease severity, but you might select another specific drug based on the comorbidities. So, for instance, if you have a patient with also a spondyl arthropathy that already failed the classic DMARDs, you will select probably a biological together with your rheumatologist that works on both diseases. If you have a patient that also has an autoimmune hepatitis, you might select a thiopurine, so you might select another drug. But for the top-down treatment, this is basically based on the disease severity, I think.
And so what might be those things then? You know, you say severe disease, I'm going to go top-down. Tell me the sort of patient you're going to do that with.
Well, we recently had a 17-year-old girl that was hospitalized at the first diagnosis, and she had a very low weight and a big abscess in her abdomen, or it was not really an abscess, a big conglomeration of bowel involved in her disease. So we started her on combination therapy with a TNF blocker and a thiopurine straight from diagnosis. Or sometimes you perform a colonoscopy and the entire colon just looks horrible with very deep ulcers, and we would start that patient on combination therapy from diagnosis.
And of course, I think it's true that in some countries, it's difficult to start top down. Are you losing much if you go for a very rapid step up?
No, I think if you start with steroids and you think it's not working after a couple of days and you go very fast, you are not losing much. No, I don't think so. But you really have to monitor the effect of your therapy very closely in patients.
And I think that's key, isn't it? If something isn't working, you've got to change. That's it's something that that we've really started to appreciate. So here's another good question, or two questions actually. How do you determine treatment success, and what do you think is a strong indicator of remission?
Well, I think it might be a bit of a simplistic approach to just select one, to be honest. I think there are various aspects of remission. So you could achieve clinical remission, but you could also have biochemical remission or endoscopic remission. And due to the fact that the correlation between symptoms and endoscopic activity is extremely poor, so to really address the aspect of remission when it comes to inflammation, then I would pick biomarkers in this sense. And as mentioned previously, we then also have to rely on these when it comes to try to monitor the disease further on.
For us, like what I try to teach the young doctors in my hospital is that we want to prevent disease progression. And to prevent disease progression, we should monitor inflammation. And you're probably going to do that with endoscopy or biomarkers. But then on the end of the road, we are working with people. And if you treat the inflammation, but your patient is still feeling very unhappy, then the treatment results is not very beneficial. So I think it's two different things. You want to control the inflammation, but besides that, you also want your patients to have a good quality of life and to be able to cope with all the aspects of life and to go to work and to go to school. For instance, I had a girl presented at a nurses symposium yesterday, and she was a young girl treated with combination therapy of infliximab and ethioprine, and she had a normal CRP, a normal calprotectin, and a normal Harvey-Bradshaw score. So I asked the nurses, so are you happy with these patients? And unfortunately, most of them told me, yes, we are happy. But I said, but this girl is not going to school because she's getting diarrhea if she eats. And she has a large fear for fecal incontinence, and she had a severe underweight when she was diagnosed, but now 1 year later she's still not eating and all the other parameters are okay. So I think controlling inflammation is the first, but also we have to look if our patients can actually have a good life with this disease.
Can I present the flip side of that to you, Jonas? And this is a common problem that we see nowadays, and that is that sometimes our patient feels well, but maybe their endoscopy or their calpro or their CRP suggests they're not well, and so we say to them, okay, you're all right, you're on these drugs, but I'm really sorry, we think you need to change something. How do you deal with that?
Well, I try to tell them what we currently know about their future disease course, and that there is a much higher risk that they will end up with surgery, for example, if this is a case of Crohn's disease, or other types of complications, such as a complicated disease behavior. And in that sense, with information to the patient, and in that way also learning them about their future disease, I think most cases it's possible then to arrive to a conclusion that you actually have to change strategy here.
And what about the ones who still say no?
Well, at least in Sweden, we're not really allowed to decide over the patients. I assume it's the same in the UK.
No, I wouldn't dare.
No, sometimes I just explain the patients like what you do, the risk for progression. If they really don't want to change, you just say, okay, in your specific case, we will do another endoscopy or MRI in half a year and discuss the same thing again. Indeed. And then, in general, you can make an agreement.
Yes. Indeed. Yeah. Absolutely. Yeah. Okay, next question. What will contribute more to the development of personalised medicine?
Well, I think, of course, but we will hear something from the next speakers that know a lot more about that, is trying to detect the underlying molecular mechanism in each individual patient. But unfortunately, we can still not do that in the clinic. And I think there's also such a thing as personalized management of patients. And that's something I'm really interested in. So we try to monitor the inflammation, the quality of life of every patient, but also the disease influencers. So we ask every patient if they smoke, if their physical activity level is okay, if they have a healthy diet, if their treatment adherence is optimal. We do that with remote monitoring in my hospital, but and we offer every individual patients interventions on those things that might influence outcome besides drug treatment only, and try to help them with the things that are particularly important for that individual patient. So I think we can do personalized management at this moment, and I hope in the future the really smart doctors will solve the more complex problems.
Because we're not great at the moment, really, at personalising medicine. It's a very inaccurate art at the moment. Okay, so in your opinion, what's the more promising direction, therefore, of future biomarker development? Genetic predisposition, microbiota, something else?
Well, if I had to choose between those two,
yes,
I would bet on the microbiota. I think with the restriction to certain aspects of adverse drug reactions, you might gain some information from the genetics, but otherwise microbiota.
Right, okay. And again, I think we're going to hear more about that soon. So thank you to both. We're going to hand over to Frank now, who's going to educate us in the world of IBD about rheumatology.
Thank you very much. And thanks for the invitation. And of course, I will not educate you. I will discuss with you some aspects of the link between inflammatory bowel disease and rheumatic diseases. And I think it's so interesting to listen to your discussion about you have a syndrome, it's not a specific disease, you have challenges with personalized, and this is all the same we have in rheumatology. So we're discussing about why it might be of importance to know what kind of selectivity our different JAK inhibitors might have to JAK 1, 2, or 3. Will in the future filgotinib superior to tofacitinib, to baricitinib, to upadacitinib, or whatever, based on their affinity to JAK 1, 2, 3, and then a patient came in and it's rheumatoid arthritis. So it's, again, a syndrome not well described. We have a rheumatoid arthritis patient with severe synovitis, others with a lower effusion in the joints and all these things. Some with early erosive disease, others without structural damage after 6 years of treatment and disease course. So I think that's so nice to hear that you are fighting with the same aspect. So this is an example, exactly what you discussed right now. What is the difference between acute inflammation and is this predicting always structural damage? So on the left-hand side, you see a power Doppler ultrasound of a peripheral joint, of a PIP joint, and on the right-hand side, you see a kind of end stage of an axial spondyloarthritis, where you see hip replacement, you see a bamboo spine, and all these things. So, of course, we want to prevent the right picture, and of course, we want to see very early these ultrasound finding, because we have learned that especially in the so-called spondyloarthritis patients group, which is mainly psoriatic arthritis and ankylosing spondylitis, or how we name it right now, axial SPA, because we are not waiting until ankylosing starts, because we want to treat earlier. These are the groups of diseases in our rheumatology field which were linked to your IBD story, and this is where we are looking for underlying inflammatory bowel diseases. And of course, we have learned that especially in these spondyloarthritic diseases, we learned that early signs are an increased vascularization on the joints, but not only on the joints, but also on the enthesial sites. So we have learned that maybe you are aware of rheumatoid arthritis, and this is a disease where we have learned that we have a kind of autoimmune disease where activated T cells going via vascularization into the joints, increasing inflammation in the synovial tissue within the capsula of the joint, and then coming a full-blown arthritis. And we have also learned that spondyloarthritis are more autoinflammatory disease and not an autoimmune disease, where a direct mechanical stress and other factors inducing the disease at the enthesial sites outside of the capsular, and then being prolonged over time, and then becomes also secondary synovitis, but not as a key feature. So, and this is why we said, okay, let's go on, start and look for enthesial sites with high mechanical stress, Achilles tendon, and look for with a sensitive biomarker, which is ultrasound power Doppler, for increased vascularization. And then you can hopefully discriminate those who are having an inflammatory rheumatic disease compared to healthy controls. And here's a table of a study where you see healthy controls are on the right-hand side. And if you look for these three last lines, you see total inflammation score in these other two groups are different to the healthy controls, as well as a damage score at the enthesial sites. And these are an ultrasound study. And now you can think about what are the two other groups where we compare with the healthy controls. Is this psoriatic arthritis, axial SBA? It's IBD. So that's funny. We see this increased vascularization in a study in IBD or patients with some alteration of the gut. And that's not arthritic patients. They are patients without any clear clinical feature of arthritis. And this is surprising for us. And then we saw, okay, this is not a specific biomarker for our diseases. It seems to be a biomarker for an overall inflammation. We don't know, but the specificity is really not very high. And coming back to this concept that the diseases linked to IBD, the spondyloarthritis, starting at the enthesial sites and not within the capsula of the joints. And we have learned a lot. We know that at least in mice models, we have T cells at the enthesial sites with the IL-23 receptor. And this is a trigger where we think that this disease starts, and later on in a full-blown inflammation, of course, we have these key cytokine players, IL-17, TNF, IL-22, IL-23, IL-18, and all the others, which later on results in structural damage in the bones and erosive disease. But if this is the case, that mechanical stress and IL-23 receptor positive T cells drives our diseases, what is an important source of IL-23? And then I come back to your. So this is a famous student from Frankfurt. I don't know if you're familiar with Julia Enders, who wrote a book during her studying that the gut is a charming organ, and it's translated in every language. I think there's no need for her anymore to be a successful physician because she earned her money anyway by writing this book. And within these books, there's a chapter explaining that it's not only relevant for nutrition, your gut, it's one of the most important organ for the immune system. And what we have learned in the past, that we now believe that the link between IBD and arthritic diseases like spondyloarthritis are linked to the dysbiosis of the gut, and there are IL-23 which get access to the circulation, and then we believe that this IL-3 will address these IL-3 receptor positive T cells at the enthesial sites and start the inflammation in combination with mechanical stress. For example, the rheumatoid arthritis, if you remember your medical studies, are never affecting the DIP joints. Have you ever get an idea why not? Is there T cells running around and say, oh, come on, it's a DIP joint, I don't go into this joint because I don't like DIPs, I prefer PIPs. No, it's not. The reason for that, but is we believe that it's really a very small tissue of synovial sites in the DIP, and we have more mechanical stress as the DIP joints compared to others. Are there any osteoarthritis at the MCP joints? No. At the DIPs? Yes. And again, this is tightly linked to our hypothesis how a disease starts in these kind of a situation with these spondyloarthritis. And if so, then we are looking for ideas when to refer to each other. And this is a paper recently published where they defined, based on the literature review, so-called red flag symptoms. So they defined major criteria and minor criteria when to refer to another specialist. And for us, we have to be trained that, of course, chronic diarrhea, rectal bleeding, fistulas, or chronic abdominal pain is a key major criteria where we, as a rheumatologist, have to refer to you as a gastroenterologist for further investigation. And the other way around, if you have an IBD patient, there are also red flags and major criteria when you have to refer to us to evaluate if there are underlying inflammatory disease, which is chronic low back pain, which is dactylitis. Do you know what dactylitis is? It's a sausage digit, which is not the most pretty nice name, but it describes exactly what it is. It's not only arthritis of all the joints of one digit, it's in addition the soft tissue swelling, which then came up with this name sausage digit. We have these enthesitis, as explained widely right now, and of course we have to look for peripheral swollen joints. So these are the so-called Mayo criteria, which came up from the whole literature review. What are the criteria when to refer to each other? And these are data from your specialists who looked for 20 years of IBD patient. What is the numbers of patients who developed arthritis, independent if it's called IBD-associated arthritis or SPA, spondyloarthritis, it doesn't matter. So you see up to 30% will have or will develop within 20 years musculoskeletal inflammation in addition to the underlying IBD. So this is why you have to take care about it. So does this influence our treatment decision and our treatment way, how we handle our patients in daily practice? Yes, for sure. If we know that a patient has an IBD, we stick much longer on a TNF inhibitor compared to those without IBD. So when we knowing that the patient has an underlying IBD, we are happy to have a TNF inhibitor because we have IL-17 on the market in these axial SPA, we have IL-23 and all these things. And of course, we will stick longer on a TNF when knowing that this disease is underlying. Coming back to the idea that the gut and the dysbiosis and the microbiome, and you mentioned that it might be the most promising biomarker in the future, is of importance. So this is the microbiome, and it's really hard for me to handle this microbiome as a rheumatologist. So I'm happy to handle with synovitis and with fibroblasts and with cytokines, but now we have to collect stool in our outpatient clinics. That's a challenge. So you see these microbiome setting and diversity here on healthy controls. This is IBD, and this is axial spondyloarthritis. So we have an altered microbiome setting in a way that is linked to chronic inflammatory bowel diseases. And what we have also, and so this is maybe linked to the disease. And do we as rheumatologists right now influencing the microbiome by our treatment intervention? So there are data out from the last two American College of Rheumatology annual meetings showing both in mice as well as in human that the microbiome will be influenced if we decide to either treat with an TNF inhibitor or treating with an IL-17 inhibitor, where we induce more firmicutes by a IL-17 blocker compared to a TNF inhibitor, where we have an unchanged microbiome setting over time. What does it mean? We do not know. At present, everybody knows that IL-17 has no positive effect on IBD. That's what we have learned from frustrant studies done in IBD. But of course, it's the only biological after TNF which has demonstrated effectiveness in axial spondyloarthropathies. So this is a challenge for us. So what should we do right now? Should we do in the future calprotectin from the beginning to say, if it's negative, we start with IL-17 to have as a backup a TNF in case he will develop an IBD in the future? Or should we do it the other way around? If calprotectin is negative, we start with a TNF to prevent them to developing an underlying IBD later on in the disease course if it's not already there. So these are the cases we have to discuss in an interdisciplinary setting. And of course, I'm privileged a little bit in Frankfurt, so we have Irina Blumenstein, my colleague at the University Hospital, but also Axel Dignas in Frankfurt, where we have a tight collaboration, and thanks for listening.
Lovely. Fantastic. Thank you. Great talk, and I hope we'll have a few moments at the end, maybe just to ask a few questions about that. So I'm going to ask Claudio Fiocchi now to come up. Thank you for coming all the way from the States, from the Cleveland Clinic, to tell us about personalised treatment of IBD, of course, but why and how?
Okay, well. Well, good evening, and I want to thank Sandoz, but also I want to thank all of you for being here. It's Friday afternoon, after all. It's 7:10, and there are many other things that could be done at this time of the day at the end of the week. So, thank you. And I will talk about something that, for those of you that have been coming to ECCO for 2-3 years, this particular ECCO was interesting because you could see a lot of the stuff that I've been preaching for the last 3-4 years becoming more common presence. You see a lot of posters and presentation when you hear about system biology, heat maps, networks, omics integration. So what I've noticed is a change in the perception of what needs to be studied in IBD to make progress. And it's a very welcome change. So, what is this? Everybody is unique. This is the cover page of an article in National Geographic, which is a widely spread, high-level, magazine of the US that everybody reads. Why a journal like National Geographic has an article on personalized medicine? Because the public knows about personalized medicine. You hear the words personalized medicine, specialized regimen, and so on. So this is becoming something that is common knowledge, or at least common curiosity. And we hear that apply to IBD or other autoimmune diseases or chronic inflammatory diseases. We want to find therapies that are so good that every person will benefit from it. So if we do that, why do we talk about personalized treatment? Because it's novel, or because it's something that actually has potential? So those of you that are gastroenterologists should be familiar with what you see there. You don't realize that when you see a patient potentially with inflammatory bowel disease, you suspect IBD, you do so many things before you arrive to a diagnosis and therapy. And you find that's very normal. But look at the steps that you take. And how long does it take before each one of us is sure, quote unquote, that this patient has Crohn's disease or ulcerative colitis? It takes weeks, often months. So we're not doing very well at that step. And the disease progresses during the time the patient is symptomatic and is come to you, and you test, and then you try to make a decision. And at the end, you make a decision, and the biologics are fashionable, they're effective to some degree, and so how good are they in the long term? Which is, inducing remission in IBD is not that difficult. Keeping the patient out of remission is very difficult. This is a slide from Dr. Colombel, which I love because you see what you have at the end of a year. You have success which varies from 20 to 35%. So when we have therapies, the most advanced therapies, that give us that kind of a barely acceptable success, we're clearly not doing that great. So what are we doing? Let's ask a question. First of all, our therapies are very lopsided. Of all the components of IBD, the environment, the genes, the immune system, and so on, all are we doing is one thing: suppress the immune system. Does that make sense? Yes, makes sense. We have inflammation, the immune system is activated, let's put them in a cage. Let's lock it up. Let's eliminate it. What are we doing by doing that? Are we treating the disease as a whole? We know that it's a complex disease by definition, or we're just treating inflammation. By the way, if somebody wants a slide, I can give it to you for free. You just send me an email, and I send it to whoever they want. Okay? I do this routinely. So we are very lopsided, very looking in one way only about treatment. And if we look at the components of IBD that have been studied intensively in the last 10 or 20 years, how much have they contributed to help us in making better diagnosis, better treatment? Most of you are familiar with the fact that we have 242 plus association in genes, and the few that are red are the one that cause the early IBD, which is really not what we deal on a daily. And all the other genes are associated in ways that we don't understand, that we don't have any impact or any knowledge of how much they actually influence the trigger of the disease and the disease mechanism itself. And from the time we're born until we die, we're constantly exposed to environmental exposures that we don't know what they are, we don't know how often, which one are positive, which one are negatives, but they are inevitable. And probably the most important influence from the mechanistic standpoint are the one that happens very early in life. Simply because one of your patients comes to you when he's 25, has symptoms, you don't know when the disease started. Did it start last week, last month, or it started in utero? There is data showing clearly that mothers that have problems, a variety of problems, like obesity, for instance, have children, have offspring. We already have intestinal inflammation, which may be silent for years and years and years until they're so severe that the symptoms appear, and then the patient goes to the doctor. And the environment is interesting. It's very difficult to study. This is a recent paper from India, very detailed, where they study population in the Kashmir area, which is high mountains, beautiful area, and then they went into the sea level in the rural areas and in Bombay, which is, sea level, but is very urban. And these people use very different environments. They use very different foods, and they even study the cooking oil that they use in each of these, and these are all different. And but no surprise, every subset of this population in the same country have a different microbiota. So measuring the microbiota, and I agree that is a potentially important biomarkers, is very difficult. There are tremendous variations. There are no two people in this room with the same microbiota. Absolutely not. And when we look at the immune system, which has been the target of our attention, everything influences the immune system. If you measure cytokines, but they study, they took 500 individuals, and they studied variations of the immune response over time, which is something we seldom do in IBD. The genes, the microbiota, and everything influences the immune response. So you see a tremendous amount of variability and heterogeneity, which is reflected at the clinical level in patients that may seem similar, but they don't respond to the same treatment. And this is a study one of my colleagues at the Cleveland Clinic is doing. You do natural language, which is a way to teach the computer to read the charts of the patients. This is a study doing for 24 months, for 2 years, where patients with symptomatic active disease were followed up by reading what the doctors were saying and writing in the chart. And you can see that although they all started with a particular clinical state in green, some of them will continue like that with active disease, some of them will continue with in blue, and some of them will continue in brown, which are different clinical states. But then you see that about 50% of the original population fluctuates over time between active disease, inactive disease, and so on. As they do that, the immune parameters change and the microbiota change as the symptoms change. So we're dealing with very heterogeneous and very dynamic situations. And we study patients at one point in time. We don't know what happened last month. We don't know what was going to happen next month. And those are tremendous difficulties that limit our ability of zero in really effective treatment. So we have a reason why we want to change, and maybe personalized therapy is the answer. If it is, how do we do that? Well, let's be humble to start with. We all went to medical school, or most of us did. We learn and we're taught how to diagnose and treat. And we are in a cage, in a mental cage, where we can only think in certain ways. The patient must have diarrhea, abdominal pain, and bleeding, and then, comes to you and it says, there's a, and you say, this patient is young, IBD. Okay, and that's a reasonable approach, but it's a very limited approach. Why? Because humans have a limited capacity to retain data and to process data. There are studies showing that normally one of us can deal with 5 pieces of information at one time, but when you go to 6 or 7, we fail to process correctly. So we're not very good, we're not very effective, unless you are special, you're very smart, or you're gifted by whatever, but God makes you better than others. So we are limited. So if we're limited, let's use something which is better than us. As a doctor, you have an obligation to do the most for your patients. And what can do better than us? The guy on the right. And what is that? It's an artificial brain, artificial intelligence, or methodologies that go beyond our individual human capacity of analyzing data. In 2017, Scientific American, which is a highly prestigious journal, published the 10 breakthrough for the year 2017. 3 of those were related to advancing medicine. And two of them, one was quantum computer, we're not going to touch on that, but computer deep learning. What is that? Computer deep learning is a way to better analyze data in greater depth. So if we have those tools, why don't we put them together and maybe find new ways and have true breakthroughs in inflammatory bowel disease? And here comes the definition of ohms and omics in the biology. Ohms means in Greek, everything. So when we study microbiome, it's all the microbiome. Starting with, they say, oh, the proteus bacteria went up or went down. Fine, what happened to the rest of the bacteria, of the fungi, of the viruses? System biology is simply a computational model of big data. Incidentally, this is something that happens in the real world outside of medicine. Medicine is a very conservative group of people. They always think in one way, and the world goes forward, and we stay behind. And I might say the IBD community is one of the most conservative physicians in the world. Not by my word, but people from the NIH. And precision medicine is exactly the use of new tools to do better treatment at the individual level. So what do? What we do normally is on top, what is called classical biology. We study the components of IBD, this ohm, that ohm, that ohm, and we expand the knowledge in each one of those fields. But if we say that IBD is the result of the integration of that knowledge, the knowledge remains separate, we're not going to find the real mechanism. We're not going to find the magic biomarkers that tells about the disease, not how much inflammation is in the gut. What we have to do is a system biology approach, which is simply integration of knowledge as the knowledge expands. That will give you two potentials. One is the famous biomarkers that everybody dreams about. I don't believe in group biomarkers. I believe in individualized biomarkers, and then approaches to therapy in a single but very focused approach. If you look at some of the abstracts that I saw at this meeting, people are starting to integrate clinical knowledge, clinical decisions with proteomics, transcriptomics, microbiomics, and that is a step forward in the right direction. But biomarkers that tell you what you want to know from the patient, they don't exist if we think about the patient as a group. If we say the patients are heterogeneous, why would we expect the same biomarkers? It doesn't make any sense. But look what we do in classical biology. There's a group of patients, some are yellow, some are green, some are blue, some are red. And the patient comes to our office, and we use our tools, the one that I showed in the first slide. And then we use our knowledge. I, as a doctor, have a certain amount of knowledge. Another doctor may have more, may have less, but that's all I have, okay? And I have experience. I graduated a year ago from medical school for my fellowship in GI, or I have 20 years of experience in GI. I'm going to process that information differently. But I'm doing a clinical classification, and I come up with this happy group, the serious group, and the serial group. All of them have IBD, but they are heterogeneous. What am I doing? I give them the same anti-inflammatory therapy, the same signaling blocker, the same integrin blocker, the same anti-this or anti-that, which are effective for some time until you switch. If we do a system biology and we take those groups, those heterogeneous groups, and we do deep molecular tool profiling, then we're going to end up with molecular classification. And then you'll see that the groups become the pink group, the orange group, the blue group, and the green group. What is a group? Are people or patients that have the same underlying molecular mechanism. If I know that, then I know how to specialize my treatment, how to personalize my treatment. And for the red group, I'm going to give a red pill. For the orange, I'm going to give an orange pill. And for the blue, a blue. And for the green, a green. That's the essence of personalized medicine. Target in what a specific group of individuals, patients, or the single patients actually need, because their mechanism in the patient is different from everybody else. An example of this approach that can be done nowadays, but not easily, and you need collaboration with people that actually know bioinformatics, is this. One of my colleagues generated this information, this network, and this network has many, many SNPs that are related to IBD at the genetic level, and they are all interrelated. And what is not showing here, which is also present in that work, are also zonulin, also tight junction molecules. So you can identify network that control not just one cytokine, but a bunch of them in network fashion, in addition to epithelial cells biology. So, and this network, then you can target the network by doing certain association between the structure of the network, the key molecule in the center of the network is something which is the module, which are the key components of the network, and you can match those molecules with databases of structures biology with particular target. In this particular case, my colleague identified a acetylate inhibitor, which is really controlling all those genes with one single drug. So, in addition to this, we have to consider what I show in the first slides of the how. The patients change over time. Here's an individual, which I call IBD prone, which doesn't have IBD, correct? But is a person that was born with a particular genetic makeup, maybe has an IBD variant, and has a particular methylation profile which reflects his exposure to the environment. And you can see what's called a heat map, which is, kind of white, pink, and blue, which is normal. This person has a particular gene expression, which leads to a particular interactome, which is a molecular structure of this disease, and it has physiological inflammation of the gut. The mucosa is nice, it's shiny, it's pink, okay? It's perfectly normal. Then, something happens, something that we don't know, a trigger, and the patient develops symptoms of IBD. What happens? The methylation profile, which is the influence of the gene plus the environment, has changed. With that, the gene expression changes, the interactome changes, and the biological response at this particular time is dominated by TNF. So an anti-TNF will be effective. But time goes on, and here we go, and the patient gets a viral infection. The methylome profile will change, the gene expression will change, so the interactome, and now has a disturbed cell signaling as the dominant biological response. And that patient will respond better to a JAK inhibitor, perhaps. And then the patient makes the bad decision, he has a Crohn's disease patient, and starts smoking. And other environmental factors. The methylome will change, gene expression will change, the interactome will change, and now disrupt cell signaling or homing happens. Maybe an integrin blocker will work better. And then the patient goes to a strange exotic country and gets a nice enteric infection, has another flare-up with another change of the methylome, the interactome, and now maybe a probiotic or an antibiotic is what is needed. So we have to accept the extreme complexity of the disease, and we need to develop the tools necessary to measure that, and that will give us personalized treatment. This is not around the corner, but the methodologies exist, and we have to accept them. They will be incorporated in clinical practice within 5 to 10 years. Thank you.
Thank you. Fantastic talk, as always. Now, we do have some time for question and answers, and I think I can see roving microphones. So if you do have a question, then please stick up your hand or just shout out. If not, then I'm going to quiz our speakers about some of the things that they've been telling us. So, in fact, I'm going to start. With Claudio. So, when I first started doing inflammatory bowel disease, gosh, about 20 years ago now, I'm slightly surprised to think, the person who inspired me, a man called David Rampton in London, was saying to me, well, by the time you're my age, genetics will have told us what we need to know. We'll have IBD1, IBD2, IBD3. And of course, that didn't really come to pass. But whenever I hear you speak, I think, well, he was right. He was slightly in the wrong way, but he was right. It's just we haven't quite got there. So the question is, how far are we away from this? Which it looks fantastic, it sounds fantastic, it is fantastic.
It is fantastic.
But when's it going to happen?
Well, to answer the question, everything happens when you have tools. Tools cost money. When I did the first study on genetic profiling, we did 4 chips, and together with a colleague, and it cost us $16,000. And we published a nice paper because it was so new. Now those 4 chips cost probably $5 each. So that allows to do all the genetic profiling and the publication that have loaded the literature, correct? So, but that's one of the components. As that happens, everything else will go through the same process. But what is really needed is not the machines or the tools. You can go to any company and say, give me the proteome, give me the transcriptome, give me the metabolome. Those are, you can buy that. They're expensive, but if you have money, you can buy them. What you need, okay, here's your chip with the information. There are 3 million pieces of data here. What do I do as a doctor? I have no idea. I'm a doctor. I need somebody to tell me how to analyze this data. I have to have a bioinformatician to help me. But not just, okay, you're a bioinformatician, take my chip, give me the data. You need to tell him, this is the data from a patient, and you have to tell him, explain the biology and what your expectations are. They know how to analyze, but they don't know what are they analyzing. And it's a combination of my knowledge as a physician and the knowledge of the cruncher to give us the answer. And those collaborations are very hard to find these days. And there are very few people from the bioinformatics world that know biology because their brain is different from ours. We have to work together.
I'm slightly relieved to know that I am going to have a job at least for the next 20 years. Although there is one thing that doctors will always be needed for, and that's to communicate. And I think it's an enormous part of our job, particularly in inflammatory bowel disease.
If I may say, this sounds awful to most doctors. I don't think that doctors are going to have a long life. Even though there are lots of articles say, what is the future of doctors and artificial intelligence? Is artificial intelligence taking over? Oh no, because the doctor this, because the doctor that, the patient still wants the tap in the back. Yeah. That's going to disappear. Young patients are not like the old one. They want their hands held and say, oh no. The young patient is going to be on the iPhone and say, okay doctor, what's my pill? And that's the future. So the humanistic part of medicine, I don't think it's going to last forever.
It's slightly scary.
It's terrible, but it's true.
I might move on then, if you don't mind. So Frank, so rheumatology certainly has some really quite significant interaction with IBD. And you mentioned that you work with great doctors like Axel. I think one of the problems is that we probably don't work together close enough. Because in fact, you're right, some of those patients need that joint approach. How can we achieve that?
Yeah, so that's an interesting question. So normally the referral strategy is maybe a starting point, but this will not solve an issue because the problem is then you are sitting in front of a patient and having acute symptoms of the musculoskeletal system plus diarrhea. Then you say, okay, normally I would switch now from whatever to IL-23. So, but I think we have to always include the rheumatologist. So go to the rheumatologist, and then you made an appointment 2 weeks. Oh, normally in rheumatology, 5 months later, you get an appointment at a rheumatologist. He said, "Okay, IL-23 is a bad idea. I would prefer to have IL-17 because of the structure of the spine." You say that's not a good idea. Then we are playing ping pong, and the patient is confused. And the good thing is to make a decision right now. So we have implemented these joint clinics where we see simultaneously mainly or more advanced right now with our dermatologists on psoriatic arthritis, psoriasis, lupus, and all these things. But I think we're starting right now to build up these inflammation centers. And I think this is maybe prior that we were no need for a physician anymore. Maybe we need other physicians which were broad certificate for autoimmune and inflammatory diseases, because I think I have a tighter link to my IBD specialist than the IBD specialist at the same department to her hepatitis C specialist. So, and this is why we build up now, and maybe it's easier at university settings, these inflammatory centers like university cancer centers where derms and radiologists and pathologists working together. Now we have these inflammatory centers. And
I would like to add to that it's very interesting to do that. If you make some sort of blueprint for all chronic diseases, maybe even, then you can help the patients with all the aspects that come with a chronic disease with the same paramedics, because there's a lot of anxiety in chronic diseases. You don't need a different psychologist for an spondyloarthropathy patient or an IBD patient. You can train You can like have a very good stop smoking outpatient clinic for the type 1 diabetes and the Crohn's patients. So it can also help to organize
right. I think it's
the supportive care.
Yeah, it's an effort to implement these, but at the end, it's not more time consuming, because if it's so time consuming reading a letter from you, and then writing a letter to you, reading another reply,
talking to an angry patient,
talking to a frustrated patient, hanging up the phone and say, "Come on, guys, we must come up to a decision right now." So sometimes it's not really time consuming if you have it on site. And then we said, all of the specialists have the right to refer to our combined outpatient clinic. So the gastroenterologist could send it because of a question of arthritis or skin, and the dermatologist because of questions about IBD or whatever. And then we see these patients together and make immediate decision, and this is an advantage. But of course, it's an ideal world prior to we have run out of time and we're only running out with these iPhones anymore. But in between, we have a chance to make combined clinics.
And so in the last 60 seconds to our two question answerers from the post-it session, this symposium was about personalised medicine, and we've heard about the future, but what about the now? Give me just how can we actually use personalised medicine in our current lives today?
So I think, as Marieke alluded to, there are limited aspects of personalized medicine. We have some clinical aspects and a clinical-based personalized approach, and then make use of those tools that we have, like thiopurine treatment. You could use TDM when it comes to the anti-TNF drugs, take into account aspects of mono versus combo treatment and so on.
Marieke, any last words?
Okay, yeah, you can monitor your patients personalized and help them with all these specific disease influencers that are especially important for that specific patients, and we can do that we can do that at present, and also take into account the preferences of the patients, for instance, choosing infusion therapy or subcutaneous therapy, or do remote monitoring or regular control visits. So this is also personalized medicine, and we can start with that, I think, immediately.
Right, and it's a beautiful way to finish off with the sort of actually the realities of personalised medicine now, coming back from Claudio's fascinating future, which I hope isn't too close now, because I do have a mortgage to pay for the future. So I'd like to thank all of our speakers for a fantastic set of talks, an interesting discussion, and as Claudio said, I'd really like to thank you all for turning up this evening. Hopefully some of you are going to the ECCO party, but don't have too good a night, because there's a fascinating set of talks tomorrow morning. And thankfully, and finally, I'd like to thank Sandoz very much indeed for putting on the symposium. And if you would all please just feedback on the way out, that'd be really great. Thank you, and enjoy the rest of ECCO.